Hi, everyone. Welcome to Grand Rounds today. I have the pleasure of introducing our speaker, Dr. Mark Wainwright. Dr. Wainwright is a pediatric neurologist and professor of neurology and head of the Division of Neurology at Seattle Children's Hospital. He is from Liverpool, England, and completed his MD and PhD at the University of Chicago, followed by training in pediatrics and neurology at the University of North Carolina and Duke University. His specific interest is in pediatric neurocritical care, including cardiac arrest, refractory status epilepticus, stroke, traumatic brain injury, and brain infections, and neurological complications of critical illness. We look forward to his talk today, entitled Pediatric Disorders of Consciousness, Neuroprotection and Neuroprognostication.
Well, good morning, and thank you for that introduction. I struggled in thinking about how to give this presentation. I've become interested in pediatric disorders of consciousness arising out of my clinical focus on ICU neurology, and this realizing the extent of the disconnect between what we do to protect the brain in critically ill children and the lack of our understanding in the mechanisms of consciousness and how what we do practice to protect the brain in the ICU, how that may improve or diminish the risk of disorders of consciousness in the long term. And that's really what I want to talk about today. I don't have any relevant disclosures other than to say I don't have any answers. As I was putting together this talk, generally one wants to have a talk which provides at least some definitive statements if you can, but a lot of what I wanted to highlight today are the enormous gaps in our understanding and our clinical practice as it relates to neuroprotection in the ICU and disorders of consciousness. So I'm going to talk about the limitations of the definitions of disorders of consciousness in children. I'll highlight the diversity of pathologies of primary and secondary neurologic insults in critically ill children. I'll then talk about the ethical dilemmas that poses. I'm no expert in this field. As I thought about what to talk about here, these are really questions that actually are forced upon you as a clinician as you're thinking about what's in the best interest of a child. And I'll end by talking a little bit about the implications for brain-directed critical care for children. The recent literature on the definitions of disorders of consciousness, this is a great review of this and the ethics in this field by Dr. Adler and colleagues, quotes Wittgenstein commonly. And one of the reasons for that, I think, is because Wittgenstein's theories of logic, language, how language acquires meaning can be reduced often to a couple of statements. One is, in the beginning is the deed, in the deed, a quote from Goethe, or meaning is use. And that's particularly relevant as we think about the challenges for disorders of consciousness in children. This is a field in which obviously consciousness has been defined by action in response to an external stimulus. And Wittgenstein's name appears periodically in this literature. I'm going to come back to this theme at the end of this talk for reasons which will become apparent as I go through. But here we have one of the cardinal problems we face is the very different definition of a disorder of consciousness by an action, and in children in particular. And this is a particular relevance for Wittgensteinian philosophy, is the importance of language. And if language the meaning of language is acquired by use, how do you apply a meaningful interpretation of consciousness to children who have no language? So this theme will be consistent throughout this talk. So this difficulties in or limitations of the definition of disorders of consciousness for children is highlighted in looking at the recent, relatively recent now, 2018 and onwards, practice guidelines for the definitions of disorders of consciousness in the US and in Europe. Just for definitions, I'm sure you're all familiar with. We have a spectrum from coma, vegetative or unresponsive wakefulness, and a minimally conscious state with and without language processing. You can see already the challenges poses to children who are pre-verbal. Another way of highlighting these issues, and particularly one that forces itself upon you when you're trying to practice neurology in the pediatric ICUs or the neonatal ICU, in my case mainly the pediatric cardiac ICU. You're thinking about what to do to protect the brain. You know, one of the characteristics of pediatric neurocritical care is the relative dearth of validated data shown for intervention shown to improve outcome. That's certainly true for cardiac arrest and traumatic brain injury, for which we have the most data. And so if one's then beginning to think about how do we increase the likelihood of recovery from disorder of consciousness, however you define that, or decrease the likelihood that that's going to occur for care that's delivered during resuscitation in the ICU, or any stage really during when the child's sick enough to be in an ICU. This is another theme here, the link between the mechanisms that we generally act to identify and mitigate, and the etiology of disorder of consciousness, or promoting the capacity to recover from that. You really don't understand that at all. The things that we talk about, ischemia, reperfusion injury, cytotoxic and vasogenic edema, the disruption of the neurovascular bundle, the disruption of autoregulation, the mechanisms of cell death, and the things that one can try to do, even if they're as basic as temperature control, the management of blood pressure, some other metabolic interventions, the control of seizures. We don't know how those connect in any way, if at all, to disorder of consciousness. Yet this is a theme, that this is and emerged as a huge gap in our practice. So the gap in ICU practice between not just identification of these disorders when if and when we arrive at a multimodal definition of those disorders in the ICU or later, but linking that to actual practice, that's another area that is yet to be addressed in this field. So there are, as I mentioned, as I'm sure you're familiar with, European and US guidelines, but they are indeed based on adult data. The AAN guidelines 2018 do include 3 recommendations for the care for children with prolonged disorders of consciousness, and that's shown here. So the confounding conditions should be treated. The disorder of consciousness should be identified using reliable and standardized behavioral assessments, but as I'll show, there are not many of those. So and there's 2 other recommendations about counseling families, that the long-term outcome is not well defined, and there are no established therapies. So really, counseling families about what the dearth of our understanding, and these will be familiar to any neurologist talking with or an intensivist talking with families in any of the ICUs. There's a very nice review by Beth Sloman and Siskar just this year on this very issue of the limitations of these scoring methods for disorders of consciousness in children. The CRSP, the Coma Recovery Scale for Pediatrics, has emerged as one of the most reliable, but they are all limited by their ability to reliably diagnose different states of disorders of consciousness in children and their validity, and they're particularly limited by in many cases the requirement for the development of language. The Molteni and colleagues published a wonderful scoping review in neurology just last year of disorders of consciousness in children. This highlights many of the gaps in this field. So this was a comprehensive review of the literature. And for the purposes of this review, they defined the disorder of consciousness as having to exist longer than 14 days, some discussion as to whether that should be longer than 28 days. One of the striking features, perhaps not that surprising in this literature review, was again the relative scarcity of literature. They identified 132 articles, but for almost 40% of them were case reports, and only 20% had more than 20 children included in them. And as they listed the quality of the literature here, you can see only in the case of etiology related to outcome were there 2 papers with high evidence. An important caveat about this is that the predominance of this literature on the relationship between etiology and outcome is traumatic brain injury and cardiac arrest. And the other feature of disorders of consciousness in critically ill children and pediatric neurocritical care is the heterogeneity of the pathophysiology of neurologic insults. It's also what makes this field both interesting and challenging, between the developmental changes in the brain and the variety of neurologic insults that lead to brain injury in critically ill children. This finding data to support practice for the treatment of those insults is really limited by their rarity and the complexity of the pathophysiology involved, and our inability to measure it. We, outside of traumatic brain injury, rarely use invasive ICP monitoring in this field. So with the limitations of the available literature, there's data for what we know clinically. Etiology is related to outcome, but importantly, that's really, majority of that is from traumatic brain injury, to some extent cardiac arrest literature. Now, that will be an important theme we'll return to. Early recovery is better, but again, this is based on early recovery of consciousness is associated with better long-term outcome, but the evidence for that is not that great. And importantly, and again, something that as many of you, I'm sure, involved in advising parents about how to think about what's in the best interest for the child, or talking about teams about adjusting the intensity of therapy or guiding therapy with the intent of promoting better long-term outcome. Late recovery from a vegetative state or unresponsive wakefulness or minimally conscious state is rare, but it reliably does occur in a variety of studies in children. One of the striking things, in clinical practice can be the gap, particularly in maybe striking clinical practice, is often a gap between the advances in basic science, basic neuroscience, and actually clinical practice for many obvious reasons. But I want to return here just to some basic neuroscience, because this has been a theme sort of forced to address as somebody trying to promote or mitigate neurologic injury and promote neurologic recovery in the ICU, in a field in which there's relatively little literature or preclinical literature to sort of help to help you in that practice. I became interested a long time ago now in glial biology, and that formed a lot of how I thought about neuroprotection in the pediatric and the cardiac ICU, the relationship between brain inflammation or glial dysfunction and neuronal injury, whether it's at the level of the neurovascular bundle or autoregulation or cytokine-mediated neurologic injury. One of the sort of fascinating papers in this area was actually published by Suki Ko when she was in Francis Jensen's lab now, almost actually 25 years ago. And it was an observation that rats, when administered canic acid on postnatal day 15, had some apoptotic cell death and seizures, but rats that had that canic acid administered on P15 and then again on postnatal day 45 had a second hit, had a much greater severity of seizures and greater apoptotic cell death compared to animals that were first exposed to canic acid as adults. This is one powerful example of how an insult early in life established susceptibility to a second neurologic insult as an adult. I found this a very striking observation. And Catherine Samara Molina, when she was a graduate student in my lab, we wondered whether glial activation, as it turned out, microglial activation, might be the mechanism that linked those two things. That is, with some change in the properties of microglia that primed them to have a greater response to a second insult later in life. And this was the work that Kathleen did, where she showed that after canic acid early in life, there was microglia were activated. These are microglia in the hippocampus. They were also activated after canic acid on induced seizures on postnatal day 45 in adult rats. But animals that have been exposed to canic acid at postnatal day 15 then got a second hit as adults at a significantly greater microglial activation. We went on to show that this could be blocked by selective targeting of microglial activation. That led to my lab. We published a variety of papers looking at the mechanisms of glial activation, the glia as a therapeutic target, the link between glial activation and seizures in a mouse traumatic brain injury model, in a variety of ways. Indeed, also looking at the role of albumin and thrombin in glial activation, the link between that activation and the loss of astrocyte glutamate transporters. And so this led us to this sort of conceptual formalization. There's nothing particularly novel about this now, but 20 years ago there was the role of glia in neurologic disease had really emerged from the Alzheimer's literature, and this was for us a fairly compelling example of a link between early life injury, a change in glial biology, and susceptibility to an insult later in life. I'm going into some detail about this work, both because I still find glial biology extremely interesting, but to make the points about the science in this way, that returning to this theme again of that insult early in life, whether it's the activation of glia, reperfusion injury, all the things that I talked about a few minutes ago, followed by a latent period free of neurologic symptoms and a greater susceptibility to neurologic injury later on. This is often how we think about why the protection we deliver to the brain in the ICU is particularly important. But if you think now in this kind of model for disorders of consciousness, the current interventions for mitigation of disorders of consciousness in children, however you define them, they're occurring really during the main focus of treatment is during the rehabilitation phase, right? Both the kinds of therapies, the drugs that may be given. we have really nothing in our, we have a relative gap in our preclinical data on the mechanisms of neurologic injury or glial dysfunction that are occurring here around the time of the primary injury and during the time in the ICU, whether it's at the cellular level, or in terms of how ICU care should be changed that would alter these mechanisms to reduce the risk for disorder of consciousness or promote their recovery. I show this slide often when I'm speaking to make the point that the scope of clinical practice for pediatric neurocritical care in terms of the disease states is very broad, and as is the mechanisms underlying them. And this goes back to the point I made a few minutes ago from the Sloman review of the strength of the literature on linking etiology to outcome. Definitely there's evidence for this, but since the evidence is mainly from traumatic brain injury and cardiac arrest, you can see how all these different other mechanisms of injury, we have even less data on which to form opinions. There's another way of, making a similar point. This is a very nice study that Erika Fink did a few years ago, looking at the risk of mortality. This was an international study in a variety of etiologies in a number of countries, from CNS infection, arrest, traumatic brain injury. Not surprisingly, the mortality was highest in traumatic brain injury and cardiac arrest. But again, to make the point, there's a very wide variety of pathologies represented here. And even more recently, this is a paper from 9 pediatric ICUs looking at the occurrence of disorders of consciousness in children with severe sepsis and organ failure. And the key finding in this paper was that among this group of 401 children from 9 different centers, that the frequency of disorder of consciousness, the black columns here, in single organ failure, multi-organ failure, and other phenotypes that they described, was actually quite high, higher than would be anticipated. Now, this is really a very early stage. This was disorder of consciousness defined as a GCS less than 12. And one of the major needs for advancement of this field is multimodal, better definitions of a disorder of consciousness in children, not just based on the physical exam, but including other neurophysiological imaging modalities. So this is just to say that, as a clinician, one would expect disorders of consciousness to be a significant pathology in multi-organ failure and sepsis. But this is not merely, and the authors recognize this, is not a sufficiently sensitive approach to define it reliably. So to summarize this so far, the caveats with classifications in children: we have assessment tools that many lack reliability and validity, and are based on the acquisition of language. ICU care is not directed at promoting recovery from disorders of consciousness. We don't have reliable methods for identifying them. We don't know what the mechanisms are. The neurologic insults are heterogeneous. And after leaving the ICU, access to therapies, which is really important in determining outcome, is really variable. I'm going to show a clinical case that highlights some of the challenges here. This is a 14-month healthy female girl, and even this statement alone sort of highlights some of the problems we face in pediatrics. The adult literature, at least with certainly for older adults, there's at least, I think, some maybe not preparation, but some recognition in families that, as parents get older, there needs to be some thinking about quality of life and the value of life if there's some acute illness. Parents of a 14-month-old are not thinking in those terms at all, obviously. and the conversations that have to happen about the quality of life and value, the meaning of what long-term recovery will look like. Those are not only the parents of young children think they're ever going to need to do, they're not emotionally ready to have conversations that need to happen. So awoke from a nap. She didn't recognize her parents. She's febrile and bradycardic, and in the ED didn't track. She had abnormal pupil reactivity, was dystonic, some transaminitis, and was positive for HHV6 and rhino and enterovirus. You can see here the thalamic injury with associated edema and white matter hyperintensity. So this was an acute necrotizing encephalopathy. So treated with immune modulation at a extensive metabolic and genetic evaluation, and the only thing that emerged was a variant of unknown significance, the SCN2A. But a very a complex medical course. She's intracranial hypertension. She required an EVD. As I said, she got intensive immune modulation. She's in refractory status. She needed was in pentobarbital coma. Cumulatively thought to have a combination of HHV encephalitis and maybe some contribution from this gene mutation. 4 months later, with continued conversations with the parents about what her long-term recovery was likely to be, and with the continued caveats from the palliative care team, rehab, neurology, neurocritical care about what we were learning and what we could tell the family. She's still not tracking, no purposeful movements, significant movement disorder requiring diazepam and baclofen. It was trach and ventilator dependent, feeding through a GJ tube. And the parents asked regularly and appropriately about whether these interventions were really appropriate. And this case highlights some of the themes I've been talking about. So this is not traumatic brain injury or cardiac arrest, an insult for which at least we have some data. We provide recommendations to the parents based on clinical experience, our understanding of the mechanisms of injury, the location of the injury, and serial neurologic exams combined with other studies like EEG and MRI. Although, no, the EEG and MRI are not the types of functional MRI or connectivity analyses, for example, that are still really at the level of research. So the parents are being asked to make decisions about procedures, drugs, that with uncertain evidence for benefit from their standpoint. They don't know if they're really making a decision in the best interest of their daughter. What we are able to say consistently is the exam will change. We know clinical experience says that will happen, and it will be slow. There's not likely to be complete recovery, but we don't know what the full degree of recovery will be. But an important phenomenon that this brings out to is that the parents' understanding of the implications of a brain injury, the sophistication of their understanding changes over time as well. I'm sure you've seen this as well. They become experts in their own child's disease, the nuances of the exam, but they also can become really sophisticated advocates about what it means to say that something's in the best interest of their child, and they're thinking about what they want or what they think their child would want in terms of a quality of life changes over time as they have time to reflect on it. The other aspect of this is that different services bring different perspectives, and this can be helpful, but it can also be very, very confusing. The way we think about brain injury from taking care of children in the ICU and the mechanisms of that injury, the literature we focus on or tend to learn from, is different for neurology and critical care, different again from palliative care and physiatry. And we do have some data in this field. This is a paper we published a few years ago. looked at the presence of spindles on EEG in the first 24 hours after ROSC in children after cardiac arrest, and looked at their pediatric cerebral performance category at 6 months. And this actually grew out of an observation of just a weekly review of EEGs post-arrest. And strikingly, the presence of spindles in the first 24 hours was strongly associated with a good outcome at 6 months. One of the other caveats in this field, though, is that 6 months is not long enough. This is a nice, very nice paper from the CHOP group, just published last year, where they able to track 44 children for up to 9 years. Median follow-up was 5.6 years after cardiac arrest. So the average age at the time of arrest was around 5, and their follow-up to 5 years, really the longest follow-up in this field for this kind of cohort. It's a follow-up by telephone. Nevertheless, what they showed was that in terms of outcomes changed over time. So not surprisingly, about a third had a poor long-term outcome. This is a PCPC of 3 or 4 here. But 16% of those with an unfavorable outcome, discharge PCPC actually improved, and 14% actually worsened over that up to 5-year period. And notably, but not surprisingly, a third of the parents could not access services. It's an important caveat in this kind of literature that the access to services is a key determinant of outcome. So we have the importance of long-term follow-up for children, adding to the challenges in advising parents about how to make decisions about what's in the best interest of their child. There's another, I think, relatively underappreciated aspect of this field too. It's this, that I've quoted some literature. Those two recent, a recent paper on long-term outcome. I've shown you a review by Sloman and colleagues, the scoping review, or review of the quality of the literature on disorders of consciousness in children as it relates to outcome, predicting outcome. The Neurocritical Care Society published guidelines last year for neuroprognostication in adults after cardiac arrest, and they're exactly as one would expect. The exam, some neurophysiology, and imaging. And this is all outlined sort of very, very nicely in good practice statements. But another way of thinking about this for children is think about the kinds of experience, the knowledge of the literature that's needed to advise adults. That's as challenging or more challenging in some ways, I would suggest, for children. And anyone who's done this and understands the kind of humility that's required in making these kinds of these judgments. But what's not addressed in any of this literature, pediatric or adult, is what counts as sufficient experience or the appropriate clinical training or expertise to perform neuroprognostication and offer this advice or engage in these discussions with parents to help them come to what they believe to be a decision that's in the best interest of their child. I think this is a gap in this field as well. This idea of prognostic humility is commented on in this paper from your own center from Brian Edlow, a review of ethical considerations, mainly focused on adults, but the themes are true for children as well. It just highlights the need for humility, the risk of a misdiagnosis, and then in the ICU, when offering this advice, a time where as a families need time to think about what they believe is the right thing to do, where giving too much time, you may lose, if that's the right word, or the time may pass for a patient, somebody to pass away peacefully, and they can be left with continuing with a quality of life that they may not have wanted. This idea of the decisions about quality of life is obviously very salient in children as well. This is a very recent case in our ICU. A 13-year-old boy found down by his parents one afternoon. You can see the left cerebellar AVM here with a cerebellar hemorrhage, the associated edema, the compression of the brainstem. You can see the cerebellum, the bleed here, ischemia of the cerebellum extending throughout the brainstem, and the exam showing actually bilateral corneal pupils, no brainstem function, apart from perhaps an intermittent respiratory effort. And yet, the EEG shown here is not normal. But the EEG is active out of proportion to the neurologic exam. So here we have a relatively preserved cortical function with loss of brainstem function. As the edema here resolves, maybe there'll be some recovery of respiratory drive. But the parents here are faced with decisions about quality and value of life they never thought they would have to make. And in this, for pediatrics, in adults, the principles of autonomy first considered over beneficence and harm. But in children, most children, autonomy is not applicable in the settings of disorders of consciousness. So for children, beneficence and not doing harm are the foundations of our ethical responsibilities. And this case is really something that highlights some of that. These issues have been discussed by Rissman and Paquette from Lurie Children's a couple of years ago. And that's highlighted actually in a really difficult case. This was the Charlie Gard case from 2000, infant born in 2016 in the UK with a mitochondrial depletion syndrome, who the parents argued should be allowed to be transported to the US for experimental therapy. And the UK government denied that request, and care was withdrawn. But this case and the one that we have in our ICU now highlights the challenges of defining what's a child's best interest. First separating out what the child's interests are versus the parent's interests, and whether the parent, in this particular case with a very young child, whether the state had a role in defining, which indeed the UK government decided it did, what the child's best interests were. But the family's goals may obviously evolve over time, as does the sophistication of their thinking or their ability to struggle with these complex ethical issues in the midst of the other trauma of having a critically ill child. And there are many of the things we talked about that highlight the problems. Is the children, while the literature is mostly traumatic brain injury and cardiac arrest related, really up to like 20% of those children that I showed you will have, with a disorder of consciousness, will have some improvement in functional outcome up to a year after recovery, and maybe even longer, as the recent cardiac arrest study showed. Now, granted, some may get worse. we don't have the tools to reliably assess this, or multimodal tools, and the tools for behavioral evaluation are really quite inconsistent. And in the ICU, the other thing that's lacking for us at present is identifying which patients if we knew what a targeted intervention was to promote recovery from this disorder of consciousness, we don't yet have the tools to identify which patients can benefit from that intervention, to phenotype patients essentially. A lot of these themes were the subject of a pediatric coma and disorders of consciousness symposium that Verena Boerwinkle from UNC, Michelle Schober from Utah, and myself organized 2022, and the proceedings were published last year, and it summarizes a lot of these themes. But these gaps extend from understanding the better understanding of the neuroscience of consciousness in children, developing reliable measures to phenotype disorders of consciousness, the ability to share that data across centers, and to extend the understanding of the mechanisms of disorders of consciousness beyond the common ones of traumatic brain injury and cardiac arrest. I talked about therapies in the ICU, and therapies in general are lacking. They are used, obviously, but this was a review a couple of years ago on the available types of therapies. But they're really, a small n, variety of interventions, and a variety of medications in relatively short time windows. The interventions we do use for brain protection in the PICUs, in the ICUs, are relative to the complexity of the underpinnings of consciousness are really pretty crude. But our management of traumatic brain injury is based on thresholds. The management of post-cardiac arrest care, I've been involved in the development of this isn't a criticism of these groups, I was involved in both of them, are just the TBI guidelines of post-cardiac arrest care. They're all based on the best available literature. The best available literature really does not enable the delivery of brain-directed critical care individualized for a specific patient at different stages of their recovery. In fact, the best available data we have, I think, for brain-directed critical care in children is really multidisciplinary care based on at least the consistent use of guidelines from a multidisciplinary team. I think one of the outstanding examples of this is Jose Pineda's work when he was at WashU St. Louis. He created a neurocritical care group program with a focus on traumatic brain injury. And that's it published their results looking at the impact of a pediatric neurocritical care team on outcome after severe traumatic brain injury. And the data from 123 of the patients shown here. This was after the introduction and before the introduction of this group. And this is the likelihood of going home without assistance. This is before this was introduced, and this is adjusted for injury severity. Much higher likelihood of going home just from the introduction of a multidisciplinary team. Much lower likelihood of needing inpatient rehabilitation. There's a similar theme in work we did with Monica Valawala in the Pegasus study, looking at the impact of adherence to the guidelines for the management of severe traumatic brain injury in children. And with all the caveats of the weakness of those guidelines based on the literature, that this is a regression curve showing likelihood of survival based on the degree of adherence to guidelines. The key message here is that if the higher the degree of adherence to guideline, the lower the likelihood of death at 6 months after severe TBI. So it's consistent care, multidisciplinary care improves outcome. And what's the factors that drive adherence? We studied this as well. This was focus groups with neurosurgeons, nurses, neurologists, intensivists involved in the care of children in the ED and the ICU. And a lot of it's communication. The people believing in the credibility of the guidelines and communication between those teams. This is to make the point again in a different way that this is work from Kennedy, Krieger, and Chop, again showing in traumatic brain injury that the recovery from a disorder of consciousness in children may occur even past 1 year. In this group of 37 children, some children emerge from a minimally conscious state up to 2 years after injury. Now, this was 1 or 2 children in a group of 37, but nevertheless, that proves that this is possible. We don't yet know how to identify early on who those children are going to be, however. I started out with Wittgenstein because that he appears referred to in some of this literature, and he wrote in another outside the Tractatus, and he wrote another short essay actually in 1929. It was a lecture on ethics, and this is relevant to the cases I talked about the importance of defining value or meaning in life, and how we help parents make decisions about that. So those are ethical decisions, or as he puts it, ethics, the inquiry into what's valuable. I talked a lot about science and mechanisms of injury, or targeting mechanisms to promote neurologic recovery. But one of the themes in his work was the limits of language and how language acquires meaning. And here, as he puts it this way, our words used as we use them in science are vessels capable of only containing and conveying meaning and sense, natural meaning and sense. Ethics, if anything, is supernatural. Well, I've never talked about the supernatural in any of the talks I've given, but this is really something that's sort of, I think, forced upon you as you're thinking about these issues of how do you link the basic neuroscience to clinical practice, and have that practice be something that is actually directed towards preventing neurologic injury or improving outcome. If we this is highlighting the fact that can't rely on behavior or language to define consciousness, that the value that families place on the quality of life is something that is really an ethical decision, and one that we really need some expertise in and have to help them with. So one of the other things he said was related to the boundaries of what science can say and what language can achieve is wherever one cannot speak, one must be silent. It's a good time. I'm going to stop at this point and summarize. So progress towards treatment of disorders of consciousness in children requires a multimodal definition of consciousness for children. Young children in particular cannot be dependent on language. We need to understand the mechanisms of consciousness and ideally be able to identify those mechanisms which are tractable targets during ICU care, something which receives relatively little attention in our literature. I don't think at all this is going to be easy, but I would like to have ICU-directed care at least have some guidance towards how we might manage the mitigation of brain injury, primary or secondary, in the ICU. So there's at least some link to that practice, and either promoting long-term recovery from disorders of consciousness or decreasing the risk for them. the research in this field needs to focus on meaningful outcomes, and that's why I've talked about what meaningful means in this context. This is really an ethical question as well. Our current pediatric literature, as is common for a lot of the pediatric neurocritical care literature, is very focused on short-term outcomes and mortality. Even 6 months, as I think is implied by some of this, is a short-term outcome. And we cannot use early-stage recovery. It's not predictive of a long-term outcome. People have been doing this for a long time. You may remember the first STARE conference in 1995 or 96 or so, really arguing and showing then that in the animal models of neuroprotection, the use of a 7-day recovery in rodents, for example, as a surrogate for long-term outcome in adults following stroke was simply not adequate. We're at that kind of stage for pediatric neurocritical care as well. We're going to have to account for the complexity of mechanisms in children with acquired neurologic injury and the multiple phenotypes of those injuries. And any prognostication model is going to need validation, calibration for particular setting and etiology, and continuous updating. That means data need to be shared as well. Alas, the clinical practice, I would argue, as I mentioned earlier, I think neuroprognostication is a skill. I think it needs training, multidisciplinary input, and obviously humility. I'm going to stop at this point. Thank you for your attention. Can you comment, I think Dr. Staley, can you comment on how you weight the brainstem exam, EEG, and MRI to prognosticate in comatose, acutely brain injured children, particularly in cases with non-conclusive findings? I think with great caution and honesty and transparency, and indeed, that's a conversation, exactly the conversation we had with a family yesterday. You have to explain to families what you know and don't know about the implications of this, and it's tremendously challenging to provide them an honest assessment of the implications of brainstem injury versus relative cortical function in a way that doesn't provide false hope, establishes trust, conveys the uncertainty of what you know and don't know, and keeps the families involved in that discussion. And I think that needs to take place over time as well. But again, the recognizing that there's to some extent a time pressure, because there's a window for some patients in whom withdrawal would be is easier to do in a controlled environment of the ICU. So I think the answer to your question is not one that has any clinical pearls. It's really related to honesty, transparency, and communication with the family, engaging what they're able to hear and take in at a given time.
Great, thanks.
There are 2 questions in the Q&A, Dr. Wainwright, if you can see them.
Okay, now I see. How do we study the effects of development itself on brain recovery? We know that injury to the brain at different time points has different consequences. Yeah, I can answer that first in the negative, I think. I don't think it's possible to develop animal model or models that recapitulate all the different mechanisms of brain injury in children. as probably obvious from the complexity of the disorders that I showed. I think if we do need to know a combination of ideally we would have data on the ontogeny, a combined of imaging, likely tractography, quantitative EEG, less so the neurologic exam in the animal for obvious reasons, that recapitulate some of the developmental phases of the brain in humans as well. If we could have some of those quantitative neurophysiologic and imaging data, I think that would go some way to help us. And I don't think we need that in animal, I don't think we need that in animal models of disease, unlike the advances we've had in, say, understanding stroke or cardiac arrest or TBI in animal models. We need the ontogenetic data. This is a question about implantable devices and use of DBS or ultrasound to help with arousal. Often these patients have prolonged hospital courses and it can take a toll on the medical team in providing care. Yeah, I'll answer the second question first. I completely agree about the toll on the medical team. Taking care of, we have a unfortunate patient in the ICU now who's brain dead. Well, in fact, really, we haven't done a formal testing. The family's waiting until they're ready to declare that. But that's a very emotionally draining experience for nurses and anybody helping take care of a child under those circumstances. That requires acknowledgement of that emotional toll and support for the people doing it. For implantable devices, ultrasound, for example, yeah, I absolutely think there's a role for those, a need for them to be evaluated. Brian Appleview at Phoenix Children's is starting a study funded by PERF to look at a controlled stimulation followed by using a quantitative EEG as a readout in children with disorders of consciousness. We're a long way from being able to use that in clinical practice, but yes, I think that is a direction that we need to go. Dr. Walker, can you comment on how your prognostication conversations are or not different in cases of genetic conditions with unknown or certain prognoses? I think with a greater degree of humility, I think, and caution in that often parents, as I expect you know from your own practice, parents are expert in these disorders and they communicate with other parents as well. The balance between the need for humility, but providing parents with some confidence in your own expertise as someone with experience and knowledge that they don't have about basic neuroscience, and the ability to help them interpret data that they're trying to learn is, I think, really quite hard to do, but humility above all.
Thank you so much for that excellent talk. I will be mindful of everyone's time and give it a couple more seconds for anyone else to have last minute questions. Okay, thank you so much, Dr. Wainwright. Thank you, everyone.
It was a pleasure. Yeah, it was a real pleasure. I just wish I'd been there in person. Thanks, everyone. Cheerio.